My name is John Powers. I'm a senior medical scientist. I work here at NIH. I'm an employee of Leidos Biomedical Research, but I work here as a contractor in support of the Collaborative Clinical Research Branch within the Division of Clinical Research in the National Institutes of Allergy and Infectious Diseases. So I know this is one of the earliest talks that you're getting in the Introduction to Principles and Practice of Clinical Research course syllabus. And so what we're going to do today is really cover some topics that will be covered in much greater depth in detail later. But really what we'd like to do here is talk about how to choose a research question and then match that research question to the design of a study. And by design, I mean the actual hypothesis, the types of enrollment criteria and the outcomes. And then talk about how to design studies most efficiently, meaning how can you do that with the smallest amount of effort and the fewest number of patients enrolled in the study. So we've got 84 slides to cover in an hour and a half. I am told, last year when I did this, I was told that there were a lot of IT Connect issues, so hopefully this year, for those of you online, Daniel assures me that we fixed all those problems from last year, so hopefully this will be a lot easier for you to see. Anybody that's here in the audience that wants to ask me a question during the presentation, please just raise your hand or run up to a microphone, and I will try to remember to say the question over so that people online can actually hear the question before I give an answer to it. So the first thing to do here tonight is to actually make the distinction between what we mean by clinical research, which is what this course is about, and clinical practice. Clinical research designates an activity designed to test hypotheses and allow us to draw conclusions and thereby develop or contribute to generalizable knowledge. So in clinical research, we are not just treating an individual patient. We are trying to develop general theories or make more broader conclusions. In clinical practice, on the other hand, we're looking at interventions designed solely to enhance the well-being of an individual person. So a couple of years ago, there was a patient that came in here whose mental status was really not very good. So this was a gentleman who was out playing golf and was doing great and came in almost in a coma. He was really unresponsive. We did a number of experimental things to him. He woke up and he went home, and as far as I know, he's out playing golf and still having a good time now. Do I know that the things we did for that individual person made him better? No, I don't. And in fact, I was joking with him and his wife as he left the door. I don't know if you got better because of us or in spite of us. But in taking care of an individual patient, I was not testing a hypothesis. We were just trying to make that one person better. What happens is that oftentimes these two endeavors get mixed up sometimes. And we do want to do research that informs clinical practice. And the best questions to do research on come from clinical practice. So they are directly related, but you are not testing a hypothesis in clinical practice. This distinction got so confused that in 1979, the federal government actually put out a report called the Belmont Report on Ethics in Human Experimentation, and this distinction is actually explained in the very first section of that document because of so much confusion between it. So that also relates to that issue of how science relates to ethics, and you'll hear some more about this later in the course as well. So a study that cannot contribute to generalizable knowledge isn't ethical because you may be exposing patients to harm without being able to draw any conclusions at the end of that study. So putting patients at risk of harm, even for minor inconvenience, for no benefit to anyone, is really not a very useful endeavor for anybody. Now, in the earliest phases of when people are developing new interventions, they may actually be tested on healthy volunteers. Nothing wrong with those volunteers. So they may not benefit themselves from taking this experimental intervention, but there is knowledge gained from doing that about early toxicities of the drug, etc. So you are still able to contribute to generalizable knowledge. So the reason I'm bringing this up is that scientific validity is really not just a nice to have, but it's a requirement of all research. So when people bring up issues related to study design, it's really not just to give you a hard time, it's because it's really an integral part of the validity of the research to begin with. And that word validity gets used a lot. It's kind of like the word clinical. I was in the grocery store last week, and I was walking down the aisle that had mouthwash, and there was a mouthwash that said clinically tested on the front of the mouthwash. I don't know what that means, but the word clinical gets used a lot, and the word validity gets used a lot. But what validity means is the ability of the study to correctly answer the research question that was posed. I am also the chairperson of a scientific review board in the research network in which I work, and we actually did an analysis of the last several protocols we reviewed over the last year, and what we found was one of our biggest issues was that when we review the protocols, we often couldn't understand what the research question was. So if that's our major issue, then it means that those of us who are designing studies should be much more clear about what the research question is at the very beginning. So this sort of relates to the whole purpose of science to begin with and how we make conclusions in science. And the philosopher Bertrand Russell said, it's not what the man of science believes that distinguishes him. Notice you can tell when this was written because it's all hymns, right? But how and why he believes it. His beliefs are tentative, not dogmatic, and they are based on evidence, not on authority or intuition. So although we talk about the rise of evidence-based medicine over the last 20 or 30 years, in fact, the whole purpose of science is to gather this kind of evidence. So if you're going to come up with a research question, this is a general way to try to think about it. And we'll march through these 4 steps. One is to come up with a general research topic or an idea that you have to begin with. But usually those ideas are very broad and you need to focus them down. Once you focus down the question, you need to come up with a specific hypothesis or a description of what you are actually going to analyze. And then finally, to come up with specific aims and objectives. And while you're focusing down, it actually gets more and more detailed as you go through each of these steps. So when you submit a research protocol, if all it has in it is a good idea, that's not a research question, and you haven't completed the process of getting to that point yet. As we said earlier, these ideas come from real-life experiences that people encounter in clinical practice, and these are exactly the kinds of questions that patients ask all the time. So, for instance, they might ask, I don't feel well, what do I have? That's a diagnostic question. Once you tell them that they have a certain disease, they must say, how bad is it? In other words, they want to know the prognosis. If it's something like what I do in infectious diseases, they want to know, can I give it to my family? That's a natural history question. Is it a transmittable disease? They want to know the etiology of it. How did I get this in the first place? And then finally, when it comes to administering treatments, they want to know, is this stuff going to help me? And I should put as a caveat, is this stuff going to hurt me? So even if it's beneficial for them, does it have side effects that they're interested in as well? Clinical research often focuses on biology, but it can focus on other non-biological questions as well related to behaviors or social issues. So for instance, you may want to do a study that says, why do people come to the doctor when they have disease X? Or what behaviors influence outcomes in disease Y? There's a very interesting cardiology study that was done about 25 years ago now, where they actually compared people who adhered to medication in the placebo group to people who didn't adhere to medication in the placebo group. So neither of these groups got an active agent, but they showed that if you adhered to the placebo, you were more likely to live longer. Now that clearly cannot be due to the intervention, right, because both were inert. It means that there was some kind of behavior or something that those people were doing, or some characteristic of those kinds of patients, which helped them to live longer. So there are those things that actually influence outcomes, even on what people would call hard outcomes, like mortality. So developing better tools to evaluate and describe a disease is often a good place to start if that hasn't been done in the research area you're interested in looking at. The other step is to characterize the natural history of the disease in order to study it. If people don't know what the disease does to human beings, it's very difficult to look at how you're going to treat it. The other thing to look at is, are there valid measures of how to assess outcomes? And that actually gets to the whole issue of measurement theory. Some outcomes are very easy to measure, such as, is the person alive or dead? On the other hand, there's a whole process that people go through to develop other kinds of outcome measures, like patient-reported outcomes. And finally, you might want to just describe what are the risk factors for having certain outcomes. For instance, who is more likely to die from a certain disease, who is more likely to live, who's more likely to have complications or disability in their life, based on patient characteristics. So some examples of measurement tools would be, for instance, coming up with a severity scale. A severity scale might actually take baseline risk factors for an outcome. So for instance, if you look at people that have pneumococcal pneumonia, being older is a risk factor for death in pneumococcal pneumonia. Younger people tend to have lower mortality rates than older people, even if everything else is the same. And then another example is developing outcome measures. So for instance, one of the projects I'm involved in now is developing a patient-reported outcome scale for symptoms of influenza. So influenza is a pretty common disease, right? About everybody in this room has had influenza or influenza-like illness at some point in their life. Most people do not die when they get the flu, but you feel pretty lousy when you have it. So the question is, how do you measure lousy? So we actually went through a whole process to interview patients, find out what it was, the symptoms that were bothering them, and develop a valid scale for how to measure symptoms in those people when they were sick, and be able to track those symptoms over time to describe how they're getting better. And that gets to this issue that's fundamental to the quantitative study of any phenomenon, and that's classification. So I know, do you ever have this thing when you drive into a parking lot and it says, these parking spots are for subcompact cars only? And my car's not that small, but it's not huge either. It's not like the gigantic minivan I used to have to get driven around in when I was a kid. And I always say, well, do I qualify as a subcompact or don't I? Right? So there's this whole issue of you have to know how to classify things in order to be able to study them. So classification is recognized as the basis for all scientific generalization and is therefore an essential element of statistical methodology as well. Uniform definitions and uniform systems of classification are prerequisites in the advancement of scientific knowledge. In the study of illness and death, therefore, a standard classification of disease and injury for statistical purposes is essential. So what's interesting now is that we have these various forms of injury and causes of death. In fact, it was just implemented a couple of weeks ago, was the ICD-10, the 10th version of this thing that came out in 1957. But guess what that's used for these days? It's used for billing purposes. It is not used for actually characterizing accurately whether someone actually has a disease or not. So again, this gets to the issue of appropriately characterizing these things in order to be able to describe it. If a milliliter for me in my lab is not the same as a milliliter for you in your lab, we can't replicate the experiment together. So this is just a graphic that looks at the different kinds of questions that you could ask that are all related to each other that may be something other than biology. You can ask environmental questions, social and cultural questions, cognitive questions, how do people think about a specific problem, and then also behavioral questions as well, and how those all might impact outcomes. It's interesting that we think about only biology as affecting outcomes and write these other things off as being soft outcomes. Yet, in fact, they do indeed impact even things like mortality. So they are useful areas for study. So let's start on our 4 steps. So first you have to choose a broad topic. One of the things you want to do is choose something that's really interesting to you. And that is because you're going to have to do a lot of work to go through this process. And if you're not interested in it from the beginning, you're going to lose steam and it's not going to be something you're going to complete. You also want to choose a topic that's timely and relevant because other people are going to ask you the question, so what? What's the big deal? Why do we need to study this in the first place? So it's a question that you should answer before somebody else asks you that question. You also want to choose a topic that is answerable, keeping in mind time and resource constraints. And so Hulley and Cummings, in their book Designing Clinical Research, actually came up with this acronym called FINER. And that is something that's feasible, interesting, novel, ethical, and relevant. And I just want to put an aside in here about the feasible piece. Unfortunately, to fit into the acronym FINER, feasible comes first, when it actually should come last. So there are many things you could do that are feasible. You could go out and study 5 patients with a given disease, but that wouldn't really give you valid answers. And remember, we talked about earlier that in the absence of scientific validity, the research loses its ethical component. So feasibility is important, but if you can't do the study the right way with the question you've picked, pick a different question. Don't answer the question in a way that you're not going to get useful information. It's also very helpful to have a mentor who can help with all the facets of this project, who's done this kind of thing before to help you think through these questions. once you've picked a general topic, you need to focus that question down. And what that entails, again, we're back to the hard work piece, you need to evaluate the medical literature and other sources to evaluate the current knowledge in that research area. Maybe the question you're interested in has already been answered by somebody else. In many areas, though, much of what we think we know is less than what is generally believed. And one of the places to start with this is review articles or treatment guidelines. But really what these do is represent a synthesis of others' view on the data. And much in treatment guidelines is graded according to the strength of the evidence. There was a recent study done about 4 years ago which actually looked at the recommendations in both cardiology and infectious disease treatment guidelines. Only 11% of what was in them had been generated from randomized controlled trials, and almost half of the recommendations were based on clinician opinion. So that's a bunch of nice guys sitting around a table saying, I think thou should do this. But that's not evidence, and that's not science. So many times what you can actually get out of guidelines is actually some of the questions that still need to be answered, because even though they're in the treatment guideline based on best opinion, they haven't really been answered in a scientifically valid way. So John Ioannidis actually brought this up in an essay that he wrote in 2005, saying that for many current scientific fields, claimed research findings may often be simply accurate measures of prevailing biases. And so what he meant by this, too, is that if you don't design a study properly, you may get an answer with a p-value around it, but a p-value doesn't tell you anything about clinical meaning, nor is it a measure of bias. So a poorly designed study can get you an answer with a p-value of 0.001, but all you've done is measure what that bias was. So you got an answer that was accurate, but just more accurately wrong. And that's the point that he makes in this particular essay. So when you're looking through the medical literature, you're looking for what's already known. And I jokingly call this the knowledge gap, right? You're looking for things that we don't know already that would make good research questions for you. So the first is, how do you define the problem that you're interested in looking at? What are its clinical features? What signs, symptoms, laboratory values go along with that clinical entity? Is it known how to diagnose the problem? And what is the impact of diagnosis on outcome? So for instance, if you come up with a great diagnostic test to detect something, but that something doesn't mean anything to the patient because they're going to die of something else when they're 95 years old, it's not of much utility. So for instance, the debate about the use of prostate-specific antigen testing, where a large study done here through NIH showed that using PSA to screen men for prostate cancer really didn't change outcomes for them. Because many times you find prostate cancer that's in its early stages, that's not going to harm the person at all, and they're going to die somewhere down the line of something else. In fact, I told my doctor after that study came out, if he puts PSA on the lab test, I am crossing it off. Because a friend of mine actually jokingly called the PSA test should be renamed prostate-specific anxiety instead of the prostate-specific antigen, because you tell somebody they got a positive test, they're going to worry about it, even if the test doesn't mean a whole lot to them in the long run. So the next thing is, how big is the problem? Is this a really common problem so that the number of people affected is very high and would have a bigger public health impact, or is it something that's rare, but even if it's rare, has a huge impact on the people that actually have it? And that's the fourth question, is looking at the impact in terms of attributable morbidity and mortality. And this is often assumed in terms of people will say, well, disease X is very prevalent, but if the more minor stages of that disease are prevalent, then it's not as big an issue. In fact, I wrote a paper back in 2008 where we looked at what the impact was on antibiotics and pneumonia back in the 1930s and 40s when penicillin and sulfa drugs were first introduced. It showed that penicillin reduced mortality in young healthy people, but only by 5%. If you were older and sicker, it reduced mortality by 40%. That's huge. I mean, a 40% absolute reduction in mortality is gigantic. But what was really interesting was to show that 95% of young healthy people with pneumonia in the pre-antibiotic era got better on nothing. So the idea is, it depends who you are in terms of what the impact of the problem is. And that also gets to the issue of what are the risk factors for getting the problem in the first place. And risk factors are not necessarily causal. So for instance, you could say older people are more likely to get pneumonia. Older people are more likely to have gray hair. Gray hair does not cause you to get pneumonia. but gray hair could be a marker for getting pneumonia. So risk factors don't necessarily need to be causal to begin with. The next question you could ask is, what's the prognosis in terms of morbidity and mortality, and what factors might modify that prognosis? Because if you are doing a clinical study to describe just the natural history of the illness, those things may be impacted by who you actually study. And when you are studying treatments, those things are referred to as confounders. In other words, those things may impact outcome independent of the treatment that you're actually trying to evaluate. What interventions can actually mitigate the problem? And this is much of the research that gets done, usually, but not always, in randomized controlled trials, evaluating interventions like drugs, devices, biologics, and also even different behaviors like hand washing. Does hand washing decrease infection rates in the hospital? And then finally, there's the two questions that are, when there are effective treatments already available, there are still questions to answer about how you use them properly, how they compare to each other, and do certain interventions work better in some people than others? So that's the issue of effect modification. So for instance, we know that beta blockers do not work as well to control blood pressure in African Americans as they do in Caucasians. And then there's a big push now to do what's called comparative effectiveness research. So for instance, in cardiology, they look at more expensive medications compared to older things like diuretics and show that the newer drugs may be more expensive, but they really don't help you lower blood pressure or decrease death, strokes, and heart attacks any more than the older drugs actually do. So one of the things that you run up against when you're evaluating the medical literature in the field that you're interested in is that people believe a lot of things that may not be supported by evidence. When I was a fellow, I actually went back and there was a statement that any person with who had a kidney transplant, if they had fungus in their urine, had to be treated because they would get a fungus ball in their urine that would knock out their new kidney. So I found that in a textbook. I looked at the reference. It referenced another textbook, which referenced a paper, which was an opinion piece, which didn't have a reference. So do people really get fungus balls and knock out their kidney when they have a kidney transplant? I don't know, because when I tried to trace that information, it turned out to be one person's opinion in an editorial and not anything based on even a natural history study of people that had kidney transplants. So Daniel Boorstin, who was the head of the National Library of Congress for a number of years, wrote, "The greatest obstacle to discovery is not ignorance, it's the illusion of knowledge." And that also, for you when you're doing your research, is an issue because you have to convince people that maybe what they know isn't what they really think they know in terms of why you want to answer the question that you do. So that gets to the issue of what do we know about previous questions. Oftentimes what happens is you get into this issue of, I took a logic course when I was in college, and one of the logical fallacies is called argumentum ad verecundium, and that's arguments from authority. Well, I'm a big wig in this field and I say so, that makes it true. That's not science, though, but we often run up against this, and in fact, television is full of this stuff, right? All the talking heads on TV who say it's got to be true because I say it's true. But the real question for you as a scientist is, what is the quality of the data? What's the validity, reliability, and precision? And are there biases in the previous data? So one of the good things about the rise of meta-analyses since the 1970s is this issue that the quality of the data and potential biases in the data is taken into account when people try to look at that data synthesis for a meta-analysis. Has the evidence been independently confirmed? So is there one study that shows this treatment is effective and 10 studies that show it's not? And that's one of the basic principles of the scientific method is make an observation, develop a hypothesis, test the hypothesis in experiment, and what's point number 4? Confirmation. Because you might just get lucky or get wrong in a single study, and one of the basic tenets of when I was a fellow, we actually wrote things down in lab books. We don't do that anymore. Everything's on a computer. But the reason we wrote our experiments down is so somebody else could replicate that same experiment, not just me. So the other question is the evidence consistent across different populations? Like I said, effect modification means it might be effective in one group and not in another, or the side effects might be different in one group than another. And for interventions, we might want to look at different doses, different durations of therapy, or combinations of therapy. So after you get through that, and that's a big process, going through all that medical literature, you need to focus on one part of that knowledge or research gap, or one piece of the puzzle. You also need to think about not just your study, but how is your study going to fit into the bigger research picture? So the best kind of studies, the joke always goes, ask more questions than they answer. Meaning, once you answer one piece of this puzzle, it leads to asking all these other things that may relate to it. So, for instance, you do a research study and you show that drug X is effective in treating disease Y, but then people might want to say, well, yeah, but does it work at a lower dose? Does it work better at a higher dose? Does it work better in combination with something else? Those are all questions that might come up later. So you need to actually think about, how does this fit into the overall research plan? The best kind of questions are the ones where even a so-called negative study still gives you useful results. So for instance, the studies in using prostate-specific antigen as a screening tool, even though those studies didn't show that that was a useful screening tool, it still came up with very useful information about who may or may not need to be tested with that test. The issue here is a single study cannot possibly answer all the questions about a topic, and in fact, one of the major flaws in research is people try to answer too many things in a single study. It's kind of like trying to put 25 anchors on a boat. You're going to sink the boat if you try to answer too many things at one time. So you really want to see, how does your research fit into the overall model or theory of the problem? Once you then get to this issue of feasibility, you have to address what kinds of information are you going to need to be able to do your study. And that relates to what kinds of people are you going to study, what populations, and if it's a comparative study, you need to have a test group and a control group to compare to each other. What exposures are you going to analyze? In other words, are you testing people that get this drug versus that drug? Or is the exposure something like people who smoke versus don't smoke, or some environmental exposure? And what outcomes are you going to measure? Is it going to be death? Is it going to be some measure of disability, etc.? What kinds of information are available to you? Do you work in a hospital that's got enough information, or a system that's got enough information to do this? We recently tried to do a study here where we looked at all the positive blood cultures at the NIH Clinical Center to look at the impact of antibiotic resistance on outcomes. It turns out that the Clinical Center is actually a fairly small hospital. So doing this only here did not give us enough information to be able to answer that question. So now we're trying to collaborate with other hospitals to try to pool our data with theirs to be able to address that question. So what resources do you need to obtain the data? Is this stuff that's already available in medical charts, or are you going to need to go out and get that information? And even if the information exists, do you have access to it, or can you get access to it? And again, just to reinforce, feasibility doesn't mean using invalid methods because, well, that's all I can get around to doing. You still need to have scientific validity to justify doing the research in the first place. Now that you've focused down that question, you need to turn this into a hypothesis or a description. So people often talk about hypothesis-driven research, but if you're just doing a description, like how many people in this hospital get disease X, that is not a hypothesis. You are just describing something. And what that is actually usually hypothesis-generating research. So you may want to use that information. So I recently did a scientific review that wanted to look at comparing outcomes in patients before and after they had instituted a new treatment, or a new guideline for testing people for tuberculosis in their system. And they wanted to see what impact implementing that guideline actually had. So the guideline had only gone into effect literally a year ago. So one of our questions was, do you even know how many people are going to have tested positive for TB in the last year? Because if it's 2 people, you're not going to have much to analyze in that time frame. So they needed to do that descriptive piece first before they could go test their hypothesis. So what is a hypothesis? So a hypothesis is not a question, it's a statement. It's a statement about what the investigators believe to be true about nature and the relationships of 2 or more variables to each other. So in other words, a hypothesis doesn't say, I'm going to find out whether drug X is better than drug Y. A hypothesis is drug X is better than drug Y. And then you formulate a question around that. A hypothesis almost always entails a comparison but all research is not comparative, as I said. So you need to differentiate qualitative from quantitative research and descriptive from analytical research. Descriptive research is like what I just described, where you're going to describe the number of people in your institution who have tested positive for TB by a skin test. That's descriptive. Analytical means you are comparing one group to another in some way. It may be to compare people who have the disease versus don't to look for risk factors of getting it, or it may be able to compare people who got drug X to drug Y to see if drug X improves outcomes compared to drug Y. So qualitative and quantitative research are really two distinct endeavors, and there's more and more information coming out or more realization about the impact of qualitative research. Qualitative research is often used to generate the hypotheses that are then evaluated in a quantitative way in quantitative research. So the aim of qualitative research is a complete detailed description in words. So for instance, when we developed the outcome symptom scale for influenza, the first step was actually to interview patients who were tested positive for influenza to see what symptoms they actually had. The output of that was words. It was the patient's descriptions of what they felt when they had influenza. The second step of that project was to quantify how many people had what symptoms. That's a quantitative question. So the qualitative research develops observations for further testing, whereas the quantitative one constructs statistical methods to explain the observations. So in the qualitative research, you only know roughly in advance what you're looking for. You're kind of groping around for what you're going to test quantitatively later. On the other hand, quantitative research is not a data dredging exercise. You want to clearly state in advance what you're looking for. So the qualitative part comes early in the phases of a research project, whereas the quantitative part comes later. And the design of a qualitative study may emerge as the study unfolds. On the other hand, a quantitative study carefully lays out in advance all aspects of how the research is going to be designed and the data is going to be collected. The actual instrument in a qualitative study is the researcher themselves. So if you're doing patient interviews, what's the tool? It's the interviewer. The interviewer is asking the person questions, and the words are the output. On the other hand, in a quantitative research study, the researcher uses other tools, like, say, the questionnaire that was developed in the qualitative part, or equipment that you might have developed, or a laboratory test to collect numerical data. So the output here is numerical data rather than just descriptive words. So we already went through this. Descriptive research provides an account and delineates the components of a problem. So for instance, a case report. So I was just on service in July, and we saw someone who was neutropenic after receiving cancer therapy. It happens all the time when people get cancer chemotherapy. But this person developed epiglottitis. I don't know if you folks know what that is. Epiglottitis is what people think killed George Washington, but it usually was a child disease. It's when the epiglottis that's in your throat swells up to the point where it closes off your windpipe so you can't breathe. That hardly ever happens in people that are neutropenic, meaning their white blood cell count is low, because what do you need for your epiglottis to swell? You need white cells so that it will cause the inflammation. So the medical student that was on with us did an excellent job of actually looking back through the literature to find all the cases of epiglottitis that had ever occurred in people who were neutropenic. And we then put that together in a case series and described, here's the kinds of people that get this disease. Very useful. So if anybody else ever runs into the same problem we did, they can now look back through this and say, here's the kind of people that get this disease. Does it say that what we did for the patient is the best thing to do? No. That's a quantitative question that we couldn't answer by the use of a case series. That needs analytical research, which is testing one or more hypotheses in a quantitative fashion. The distinction is not as clear as descriptive research often contains comparisons, but you can assess causality. So I may want to say, for instance, you could look at the case series on epiglottitis and say, well, it appears there's more cases now than there used to be. But that may be because people are more aware of it and are more likely to report it. Doesn't at all mean that it's actually more common. I can't make that assessment. So the push for hypothesis-driven research tends to make descriptions sound less valuable. But these descriptions are absolutely necessary in order for you to be able to form the hypotheses that you were going to test in the future. So in other words, research is really a stepwise approach you've got to develop the question before you can answer the question. If you skip over those earlier stages or assume that it's already been done, your research may be on shaky ground to begin with. So once you've come up with that kind of a question, then you have to match the kind of study to the kind of question that you actually want to answer. So I always jokingly say, I made this graphic once on an airplane, and I think the woman sitting next to me wanted to jump out of the window because putting all these things, little lines on PowerPoint is not my forte. But what I tried to do is to try to separate this out into the different types of research of descriptive versus analytical. Notice I don't have anything under descriptive. You don't need to do anything. You just count up the number of people that have a certain disease and you describe what you saw. On the other hand, analytical research entails some kind of comparison. So there are several ways to make that comparison. The first is to divide things up into experimental versus non-experimental research. So non-experimental is often called observational research. So the distinction between these, in experimental research, it's the investigator who decides who gets what treatment or who gets what exposure. So randomized trials assign the patients to drug X or drug Y or drug X or placebo. That is done by the investigator through the process of randomization. In an observational study, the investigator doesn't have a hand in who gets what. They are just watching what happens. The clinicians in practice give what they think is best, and then the investigator counts up the results. There are three types of observational studies. One is called a cohort study, one's a case control, and then one's cross-sectional. So a cohort is one that moves forwards in time. It starts with the exposure and then looks forwards to the outcome. So you start with exposure and you go to outcome. You can do that retrospectively, meaning that the data is gathered before your hypothesis is made. So a retrospective cohort study would be me going back and looking at the last, which is essentially what we wanted to do with that study of looking at blood cultures in the clinical center. I want to compare people that had a resistant bacteria in their blood compared to people who didn't have a resistant bacteria, and then see how many people died in each group. That's a retrospective cohort study because I'm starting off with the exposure, who had the bacteria in their blood, and the outcome is death. And I'm looking forwards in time, even though the data has been collected previously, which makes it a retrospective study. A case control study does the opposite. It actually starts with the outcome and then looks backwards in time. So these are always retrospective because you're always looking backwards. So this is actually how the first studies were done, where they looked at lung cancer and smoking. So they looked at people who had lung cancer and looked back to see that more people who were smokers had gotten lung cancer than the people who didn't have lung cancer. And then finally, there's a cross-sectional study which doesn't have any time component. It just looks across the data at one particular point in time. Experimental studies can be divided up into two types, those that are randomized and those that are not randomized. So randomization is a process by which patients are assigned to given interventions randomly. So you may generate a table of numbers or even use a coin that you can flip to decide which group people go into. But it is not a systematic process of assigning folks to the interventions. Non-randomized trials don't do that. So, for instance, in a non-randomized trial, you may do what's called a historical control. You compare people who got the new treatment to people in the past who didn't get it. So, for instance, in the hospital, studies on hand washing are often done this way. So what happens is a hospital will implement a new protocol for hand washing, count up how many people get infections in the hospital, and compare it to what happened in the past when they didn't do that hand washing protocol. The problem with that is that many things can change over time in between the time when you implemented the hand washing and the time that you didn't. And so you can't really assign that the outcome is due to what you thought it was. The process of randomization allows you to assign causality to the outcomes. So if you randomize people to drug X or drug Y, everybody in the study, if randomization works, has an equal chance of dying from the disease. So nobody's different in the study at the beginning of the study, and then you follow them forwards to the outcome. The outcomes then differ based on what's the only thing different between the two groups. It's this group got the intervention and that group didn't. They were all equally likely to have a specific outcome at the beginning of the study. So what randomization does not do is account for biases that happen after the study begins. So I never saw this movie, but there's a movie called The Dictator, I guess, which is one of those Sacha Baron Cohen movies. So I guess in this movie, he's running in the Olympics in his country. He's the dictator of the country. So he's running in the race, and he starts off, and he shoots the gun off at the race, and he starts running, and he turns around, and he shoots all the other people in the race. So did they all start at exactly the same point? Absolutely. That's randomization. What happened after the study? He shoots everybody. That's missing data, right? So that randomization does not account for stuff that happens after the race has been started. So there are 4 different types of randomized trials. One is when you compare an intervention to placebo, or you compare an intervention to no specific treatment. The difference between those is that you can blind a placebo-controlled trial. Placebo means that you're giving people something that looks exactly like the thing that you're testing, so nobody knows what you're going to get. On the other hand, if you compare treatment to no treatment, people know who got what, because you can know who got no treatment and you know who got the treatment. The other kinds of trial is a dose-response trial, where you compare higher doses of the intervention to lower doses of the intervention. And lastly, there's an active controlled trial, where you compare drug X to drug Y, which have their own special issues. You can actually do those studies to evaluate whether the new intervention is better than the old one. But in what I do in infectious diseases, many of these studies are not used to evaluate that the new intervention is better. They want to rule out that the intervention is worse by some amount. And you'll hear more about that kind of specific trial design later on in the course syllabus. So let's get down to developing hypotheses. The more specific you are, the better, because people can then understand what you're trying to evaluate. So for instance, let's take the hypothesis, antibiotics are effective in ear infections in kids. Well, that doesn't tell me what antibiotic, what kinds of kids, or even what kind of ear infections. So saying amoxicillin is effective in acute otitis media in children between the ages of 2 and 6. Well, that's better. At least I'm describing the kids better. Amoxicillin is effective compared to placebo. Okay, that's even better. Now I know what I'm comparing it to. In reducing pain, okay, now I specified the outcome. In children ages 2 to 6 years with initial episodes of acute otitis media. Now I describe the disease. That's the best way to describe it. The more specific you are about your research hypothesis, the more people can understand what you're actually looking at. So that gets down to developing specific aims and objectives for your study. So once you've chosen an overall research question, that gives you the why. It's the rationale for doing the study. But then you need to answer a bunch of other questions. Who are you actually going to study? That defines the population. Where are you going to do the study? Is this going to be in hospitalized patients or outpatients or both? When are you going to do it? What's the time frame in which you're going to run the study? And is this study going to be prospective, meaning that the hypothesis comes first and now you're going to collect the data? Or is it retrospective, meaning I come up with my hypothesis, but the data has already been collected in the past that I want to look at? What variables are you actually going to measure? What interventions are you going to look at? And what are the outcomes that you're actually interested in looking at? Those things all fall into a rubric called content validity. And then how are you going to do this? What tools are you going to use to make the measurements? Oftentimes what happens is that we are sort of stuck with what we're stuck with. So in other words, if you're doing a retrospective chart review, and you want to look at how many people had disease X, you may look through the chart and it says in the chart, this patient had pneumonia. And you go to look for some confirmation of the person having pneumonia, you can't find it. It's not in the chart. Can't find an x-ray, can't find why the doctor thought this person had pneumonia. So you're stuck in retrospective data with what's already in the collected data. On the other hand, a prospective study, you can define ahead of time what you actually want to measure. For both situations, though, planning is really key. And there's a thing in the efficiency literature that says failing to plan is planning to fail. If you don't think through these things ahead of time, you're going to get stuck in a place you don't want to be because you're going to run into a problem you didn't anticipate. So my favorite is when I review protocols and you get sort of stuck into this vague language. Back in 1992, when Bill Clinton was having his issues with Monica Lewinsky, he uttered the famous, well, it depends what the definition of is. That is not the position you want to be in when you're designing clinical research. So a protocol I reviewed recently said, clinical outcomes will be divided up into clinical success and failure. Well, I hope so. Well, I don't know what that means. How is success defined? How is failure defined? So without being specific about those things, you're no more informed than you were before you read that sentence. So that gets to this issue. This is one of my favorite shows to watch on Saturday morning. It's been on for like 35 years now, is This Old House. I'm very jealous of these guys because they have every power tool known to mankind, which my wife will never let me buy. So I'm always stuck doing it by hand when these guys always have the fancy tool to be able to do it with. But they have the right tool for the job. And that's actually what you have to think about in clinical research, is you need to apply the right tools to what you're trying to do. So before we move on to talking about efficiency in clinical trials, let's talk a little about what are some of the common pitfalls that people run into when they're trying to come up with a research question and design their study. One is they let feasibility issues become paramount. And it's much better to change your question than it is to develop a research study that's invalid scientifically just because you don't have the resources or whatever you need to answer that question properly. Another one is taking on too many questions, and because you do that, you don't answer any. You've got too much information stuck into a single study, or it becomes so difficult to do that you can't accomplish it. Lack of clarity on the hypothesis and the research question to begin with, or not choosing a study design that matches the question. So one of the things I notice in infectious diseases, what I do, is we say there is an unmet medical need for this drug because there's resistance to the old drug and people are dying. And then you look at the study design, and it's not designed to show the new drug is better than the old one that you were just told was so bad. So it doesn't match the research design to what the stated problem is to begin with. And then finally, the issue we talked about of vague specific aims and variables and unclear measurement properties of the tools that you're actually using. One of the things to be very wary of is the two words that you'll see in a lot of protocols called clinician judgment. My judgment is not like my colleague's judgment, is not like the person next to his judgment or her judgment. So when you put that in there, you are inherently putting in some vagueness into the study. Sometimes that's okay. Maybe what you want to evaluate is clinician judgments. Why do clinicians make these particular judgments? But on the other hand, if you're evaluating, say, the effective interventions, if the outcome is clinician judgment, you're not really sure what you actually measure because many things go into clinician judgments. So any questions about that in terms of how to select and develop a research question? So we just spent 47 minutes talking about how to develop a research question. And the reason why we spent so much time on it is it's a process. It takes a while to do it. It is not something you're going to sit down with a pad of paper and in a half an hour develop a research question out of thin air. It takes a while to go through all that information, find out what's out there, and develop that kind of a process. So, but if you don't, you are really treading down a pathway where you could run into trouble later. And especially when it comes to the issue of getting funding for research, you're going to have to defend all those things we talked about anyway. So it makes much better sense to think about these ahead of time. So now you've got your research question, and we're going to talk about how can we design this study most efficiently. Oh, sorry, I didn't see anybody.
With regard to qualitative studies,
oh, there you are. So the question is there funding available for qualitative research as much as there is for quantitative research? And that depends upon who you ask. So there is some funding available, for instance, like when I was using the example of developing patient-reported outcomes. The first step of that is the qualitative research piece. And there are organizations, like in the Affordable Care Act, created a group called the Patient-Centered Outcome Research Institute, or PCORI, which has actually provided funding for exactly that kind of research. So there are places now specifically that you might be able to actually gather funding from those things. It actually is the same thing like we talked about with the tools. You have to go to the right place with the right question. If you go to some place that's interested in quantitative research questions and ask them to fund your qualitative study, you might not be that successful. And a lot of that is because of, this is just my personal experience, what I said at the beginning. People think they've already answered that question, when in fact they haven't. Right, so you've got to show people the literature on why that question really needs to be answered. Any other questions? This light is in my eyes, so it's hard to see if anybody's raising their hands. Okay. All right. So let's, first of all, if we're going to talk about efficiency of clinical trials, let's define what a clinical trial is, and let's define what efficiency actually means. So a clinical trial is a controlled prospective study enrolling human subjects, often used to evaluate the effectiveness and or harms of interventions in either the treatment, the prevention, or diagnosis of disease. So that's why I was joking. When I see mouthwash that's clinically tested, I doubt that they did a clinical trial comparing this type of mouthwash to that type of mouthwash. So I don't know what they mean by clinically tested. On the other hand, efficiency, at least in physics, means the ratio of useful work to the energy supplied to it. So in clinical trials, what it means is getting valid and reliable answers to important questions with the least amount of resources. You don't want to put patients at risk by doing a study that's not valid. On the other hand, you don't want to have not enough people in the study to be able to answer the question. So to be able to do a study efficiently means actually more planning, not less work. So if you want to do a study with fewer patients, that translates inversely into more work. So inverse relationship, fewer patients, more work. So because that you have to think about it ahead of time. Back in 2001, the Institute of Medicine put out this monograph, which I'm sure you'll want to read because it's 300 pages long, called Small Clinical Trials, Issues and Challenges. And in it they say, clinical trials with small numbers of participants must address broad sets of issues different from those that must be addressed in trials with large numbers of participants. It is in those circumstances of trials with small sample sizes that approaches to optimization of the study design and data interpretation pose greater challenges. In other words, that can be summarized in 2 words: more work. But that gets to the issue. What's a large or a small trial? What does that actually mean? So IOM defines a large trial as one that has adequate sample size or numbers of patients enrolled, that's what sample size means, to answer the primary research question. So large means large enough. The very first randomized trial that was ever done was in streptomycin for tuberculosis. It only had 105 patients in it because streptomycin, compared to the standard of care of the day of bed rest, lowered mortality by 20%. And it was still able to show a clinically significant difference with only 105 patients. On the other hand, some modern cardiology trials have had over 10,000 patients in them to be able to show any kind of effect at all because the effect is very small. So what means large is large enough to answer the question. A trial with very few participants, like that TB study, may still have adequate statistical power if the effect of the drug that you're testing is very large, like that one was where you had a 20% decrease in mortality. So this means balancing exposing research subjects to potential harms of the experimental intervention with the balance of obtaining valid answers. But remember, if you don't obtain valid answers, there wasn't a point to do the study to begin with. So this relates to the ethics of the study to start with. And in fact, there have been a number of editorials in the literature complaining about this issue, that trials from their inception are too small to begin with, so that you can't really answer the question that you set out to address. And so this is one editorial which actually argued that it's unethical to start those studies to begin with. The other side of the argument is that, well, if I do a small study, somebody someday is going to put that together in a meta-analysis and answer the question for real. I have to say, personally, I find that to be a very weak response. You don't know what's going to happen in the future. For those of you who are familiar with Yogi Berra, who was the famous New York Yankee who just passed away a couple weeks ago, Yogi said, prognostication is very difficult, especially when it concerns the future. So you don't know what somebody else is going to do, and that also doesn't have anything to say about the validity of your study. It doesn't explain why you should be doing this study now. If you're expecting somebody else to do it better in the future, maybe then somebody else should do it. So the IOM also says a proposed study that cannot answer the question being asked because the necessary sample size cannot be attained should not be conducted on ethical grounds. That is, it is unacceptable to expose patients or research participants to harms, even inconveniences, if there is no prospect that useful and potentially generalizable information will result from the study. That's pretty clear. So especially on what I do, there have been discussions about studies in patients who are infected with resistant pathogens talking about the use of smaller data sets. First of all, it's unclear what's meant by smaller data sets. but one could assume that what they mean is studies too small to actually answer the research question that was posed. So that would seem to violate a basic ethical premise to begin with in why you're doing the research to start with. So the other thing that the IOM says is that really doing small trials is a last resort. And it says that they should only be done when there are no alternatives. And it says this cannot be overemphasized. And the committee is not encouraging the use of small clinical trials, but rather providing advice on strategies to consider in the design and analysis of these trials. So it even says for some trials it might be impossible to definitively answer a research question with a high degree of confidence, and in those cases perhaps the best that one can do is assess the next set of questions to be asked. So again, they're saying that if you can't definitively answer the question, maybe you need to move on to a different question. So what's the issue about small numbers in a study? Why is that a problem to begin with? The problem is that the smaller the numbers of people in a study, it increases the variability of the results that you get and increases the play of chance on the results that you might actually obtain. One of the examples I always like to use is I'm a football fan. My wife would love it if fantasy football disappeared from the face of the earth because she says my mood on Sundays goes up and down depending upon how my fantasy football team is doing. So, but if you actually look at the coin flip in the Super Bowl, the NFC team, up until 2 years ago, had won the coin flip in the Super Bowl 14 years in a row. Now, what do you think that's due to? The ref cheating? The ref putting his thumb on the scales? No, because there's no correlation at all between who wins the coin flip and who wins the game. So it's not that big a deal. So what do you know is going to happen over the next succeeding 50 years of Super Bowls? Anybody? It's going to even out, right? The AFC team's going to have some long run of winning the coin flip, and it's going to end up 50-50 over the next 100 years or so. But the point is, only looking at the last 14 years of coin flips is too small. And what I'm looking at is random chance. That we happen to get 14 NFC teams winning in a row is nothing more than random chance. Is it statistically significant? You betcha. 0 out of 14 comes out to have a p-value less than 0.05. But it's wrong. It's wrong because I didn't take a random sample, and I didn't look at a sample that's big enough, which shows you why p-values do not have anything to do with bias at all. And it also means that even though you reach statistically significant results, those results may not be generalizable, or they may not even be true. So the other issue is too many variables are present in a small study to assess cause and effect. In other words, if you're looking at really sick patients, there's a lot of stuff going on with those people, and you may not be able to actually balance all those variables between the test and the control group. You may only be able to discern gross effects, like did people live or die, and have very limited ability to analyze the baseline factors which may result in death. So if you only do a study with 20 people, you're not going to be able to analyze whether older people die more often than younger people because there aren't going to be that many people in the study to be able to answer that question. And you may be completely incapable of identifying any adverse effects because you can't figure that out, especially if you study 25 people and the side effect happens in 1 in every 50 people, you may see nothing. So that gets to the other issue of absence of evidence is not evidence of absence. So the fact that you do a study and you don't see side effects of a drug doesn't mean it doesn't have side effects. It may just be related to the number of people that you actually studied. So where are the situations where smaller clinical studies may be justifiable? So they may be in rare diseases where there aren't many people who have the disease to begin with. There may be unique study populations, and by unique study populations, I will show you what the Institute of Medicine uses as the example. Astronauts in space. They're not talking about people with the disease. They're talking about really rare situations. So individually tailored therapies, environments that might be isolated, like some guy flying to Mars and who might be... By the way, I saw that movie Interstellar last night. Did anybody like that movie? They had to wake me up at the end. So, emergency situations and public health urgencies are the places where we might actually want to do these things. So while smaller clinical trials are a last resort, efficient clinical trials are always justifiable and really what you should want to be doing. So what we're going to do here is look at different methods to improve the efficiency of a study, which are useful or not, depending upon what situation we're talking about, what disease we're talking about, what research questions you're trying to answer, and what setting you're actually doing the study in. But these kinds of things are always applicable, whether you're doing a larger study or a smaller study. So first of all, we need to talk about what are the basic components of a clinical research study to begin with. Because if we're going to talk about altering some of these things to try to make the study more efficient, we've got to know what those basic building blocks are to begin with. So the first thing is that we spent the first half of this talk on is you have to have a clear objective of the study to begin with. If it's a comparative, or what I called analytical study, you need to actually have a quantitative comparison between the test group and the control group. That does not apply if it's just a descriptive study. You need to select patients for inclusion in the study. And if it's a comparative study, you need to make sure that there's baseline comparability between the test group and the control group. Now that applies if you're testing interventions. If you're looking at risk factors for an outcome, you don't need baseline comparability because that's in fact what you're trying to analyze. What are the differences between the people at baseline who get one disease versus another? You want to minimize the biases in the study. You want to have well-defined and reliable outcome measures that actually mean something to patients. Many outcome measures in clinical research studies are based on what the doctor chooses to do. So for instance, in what I do in infectious diseases, many of the studies in the past have been based on the doctor's judgment that the person doesn't need more antibiotics. But it's not clear why the doctors were making those judgments. So we've been trying to move away from that to get to more patient-centered outcomes that measure, is the patient living longer or are they living better? In other words, if they're alive, which is easy to measure, can we have some patient-centered measures that measure patient disability or patient symptoms, which actually show their ability to function in their daily lives, rather than just judging whether the doctor needs to give more medicine or not? Nobody comes to the doctor saying, my goal of being here is to get more medicine. They actually want to feel better in their lives. And then finally, appropriate statistical analysis. So that is the summary of this course, basically in a nutshell, right? You're going to hear about all these different things in much greater detail as you march through the rest of this course. But keep that slide in mind, because those are the kinds of things that you're going to hear about for the rest of the time. So a lot of this has to do with this issue. Remember, small and efficient clinical trials revolves around the issue of what's called sample size. Sample size is essentially the number of research participants or volunteers that you need to participate in your study. And I use that terminology because, first of all, it's not always right to refer to them as patients. If you're doing a survey on totally healthy people, they're not patients. Remember, patients comes from the Greek word meaning to suffer. Those people aren't suffering. You may just want to interview people who are out there in the wider community as to why they get a flu vaccine or not. Those people aren't sick. They're not patients. So, and the second thing is, for these research studies, people are really, you have to rely on the altruism of folks who sign up to volunteer to be a participant in the study. So always keep in mind that these people are research volunteers. They're helping you out by being in the study. So many variables have what's called a normal distribution, or the famous bell-shaped curve that we all learned about in grade school when we were getting A's, B's, C's, and D's. So what that means is that many data falls onto this kind of bell-shaped curve where 95% of the data is in the middle, and there's 2.5% of the data on what's called the tails of this curve. So if I took, for instance, the height of people in this room, there would be an average height, and then there would be some distribution. So if Danny DeVito walks in and Shaquille O'Neal walks in, what's going to happen is this curve is going to get broader because we're going to have people on one end and another person on way far on the other end. So keep that in mind when we talk about homogeneity in the data. So, but what I've done here is so that middle part of the curve is what's called two standard deviations from the mean. The mean is right down the middle at the top of that bell. So, but what I've done here is this is a descriptive study. I'm only looking at one curve. But what we want to do in a clinical trial that's analytical, comparing one group to another, is we want to do this. We want to compare one group to another group. So, but the clinical trials, what they do is they compare average effects in groups of research participants who are administered an intervention to another group of people who don't get the intervention. So let's look at this example here. Suppose we have two groups, and if you look down at the bottom, the one group is centered around 50, and the other group is centered around 0, down at the bottom of that. If I can actually show this right here. This is the one mean, and here's the center of this bell-shaped curve is at 50 on the other one. So there's only 12 people per group in here, and the standard deviation, which is the width of the bottom of this bell-shaped curve, is 60. And the reason that this curve is shaped this way is because we have only 12 people in the group. Now what happens if so what we want to do, what does statistically significant actually mean? So what statistically significant means is, and the p-value of 0.05, means we want this little red tail of the one group to actually fall out, the mean of this curve, to exclude all of this curve except for that little 2.5% red tail on that end. So how do we get there? The first thing I want to show you is, look at this big overlap between these curves, right? So getting a p-value of 0.05, which means there's 2.5% on this end and 2.5% on this end, doesn't mean these two curves don't overlap. They overlap a lot. It just means they don't overlap as so much that we only have this little teeny tail overlapping the mean of this group. So what happens then if we go from 12 patients and increase the number of people to 24? Can you see the difference in the shape of these curves? The curves get taller and narrower because the standard deviation is now smaller. So by increasing the number of people in the study, the variability in these measures goes down. This is only accounting for random chance and random variability. So if I was measuring height, but I used a ruler for this group that was off by 2 inches, but I used a ruler for this group that was completely accurate, that is a systematic bias in the study. This will tell me nothing about that. This is only a measure of random variability, not a measure of bias. So random variability means it's occurring equally in both groups. So again, notice there's a good deal of overlap here. We're just excluding this little tail down at the bottom. So finally, if we increase this to 48 people per group, look at this, there's hardly any overlap at all between these things. Notice the mean doesn't budge. It's still 50 and it's still 0, centered around exactly the same place, but by increasing the sample size, you have managed to decrease the variability or the standard deviation between these two curves. You haven't done anything else. Haven't changed what you're measuring, haven't changed the patient population, nothing. You've just increased the sample size. But this is what people don't want to do. They want to do a smaller study. So how do we then decrease this variability without doing this, without putting more people into the study? So that then requires some understanding of what goes into sample size. Do not sweat this. You're going to get whole lectures on this stuff. This is just toe in the water time to try to get some basic understanding of this, to understand efficiency of trials. So a sample size is based on really 4 parameters or ingredients. And there are 2 types of error in clinical trials. The one is called type 1 error. Fancy schmancy word for saying you conclude something works when it doesn't. A false positive result. A type 2 error is actually you concluding that something doesn't work when in fact it does. A false negative error. The term power, which is overused tremendously a la my namesake, is actually 1 minus the type 2 error. So type 1 error is usually that 0.05. That's where the p-value of 0.05 comes from. So a type 1 error means you would make a mistake and conclude a new drug was effective 5 times out of 100 or 1 time out of 20. So, and again, that 0.05 comes from that 2.5% tail on either side of that curve. The type 2 error is usually set at 10 or 20%. And since power is the ability to detect a difference when a difference exists, it means power is 1 minus that. So a trial with a type 2 error of 10 or 20% has a power of 80 or 90%. By the way, as an aside, you will hear more about this, there is no role for talking about these after a study is over. So these are only probabilities that occur before the study is done. So for instance, you do a study and you expect to find that drug A is 10% better than drug B. It comes out that the results show drug A is 2% better than drug B, but you can't show a difference between them because that difference was so small. So what people will say after the study is, that study was underpowered. No, it wasn't. It was not. You got the effect size wrong to begin with. That's the problem. It was not underpowered. So it's kind of like when, the Ravens are, 1-5 this year? They've only won one game all year. That was not the prediction before the year started, right? They were supposed to actually do pretty well, and now they've only won one game out of 6. Well, you can talk about, if they had this guy wasn't hurt, and if they only had this one play that didn't go south. I love when sportscasters do this. But that's why you play the game. Those things did happen, and they did lose. That's the way it is. So talking about stuff that could have happened after a study is over is irrelevant. So there is a whole literature on the overuse of the term underpowered. And what people mean by that, is if only I had done a bigger study, I would have detected a difference. And for reasons you'll hear about later, that is false. And that is because these numbers don't stay where they are. So there's something I showed you in these graphs that never happens in real life, right? When I did this and I increased the sample size, the 50 stayed at 50 and the 0 stayed at 0. That doesn't happen. Anybody want to know what phenomenon that is? You guys know, you've heard this. It's called regression to the mean. And what happens is, as the sample size gets bigger, these numbers are going to move closer to their true values. So, in other words, I think what the average male height in the United States is 5'9", and I think the average female height is 5'4", if I'm correct on that, right? So suppose we did the average in this room and it came out to be 6 feet for men and 5'2" for women. The more men and women we put into this room, what's going to happen? It's going to move towards the population mean. It is not going to stay at 6 feet, and it's not going to stay at 5'2". It's going to move towards where the true average actually is. So when people say their study is underpowered, they think that somebody came by and poured cement on this 50 and poured cement on this 0, and they can't move. And that what I showed you here, which is that the curves will just squeeze in around each other, that actually happens in real life. This, folks, is a fictional example. I was only trying to show you the issue with standard deviation and try not to move too many things on the graph. But that doesn't happen because of regression to the mean. The other two components of sample size are the variability in the data, which is called standard deviation, and finally, the treatment difference, the difference between the test group and the control group. The bigger that difference is, the less number of people you need to actually show that. That's sometimes also called the effect size, or it can be called the delta as well. So here's the two things you're looking at. Variability in the data is the width of this curve, and the treatment effect size is the difference between the means of the two curves. By making these curves further apart and increasing the effect size, you can have a smaller sample size. By making the base of this narrower, by decreasing variability, you can have a smaller sample size. So now that we got that background, how are we going to actually make these trials more efficient? So there's really 4 ways to actually do this, and we'll go through them one at a time. The first is to have a more focused and relevant research question. So the research question we already talked about needs to be one that's worth answering, but focusing it on a more homogeneous population actually allows you to have less variability in the data. So if I only do a study in people over 65, the data is going to be more homogeneous than I do a study that goes from neonates all the way to 95-year-olds. So the other issue here is that it's really important to calculate a sample size after you come up with a research question. Not start off with the sample size and back calculate to the research question. Because what happens when people do that is you end up usually overestimating the effect size, coming up with a sample size that's too small, and you can't really answer the question to begin with. The second thing you could do is change those ingredients of the sample size. Remember I said there's a type 1 and a type 2 error? That is not suggested that you actually do this. But if you allow more error in the study, you will get away with a smaller sample size. But when you think about it, a p-value of 0.05 or a type 1 error of 0.05 means you're wrong 1 in 20 times. If you don't think that's a lot, go on to clinicaltrials.gov and see how many thousands and thousands and thousands of studies there are out there. 1 in 20 is a lot. If you were wrong that many times, we'd be really getting things wrong. The other thing I joke with the fellows is, if you don't think patients care about an error rate that high, just hang a sign on your office door that says, "Guess what? I'm wrong 1 in 20 times," and watch people run out of the waiting room. That is a pretty high level of error. It's also why people usually ask for confirmation of results, because if you get confirmation of results, you're much less likely to be wrong. If you increase the type 2 error rate, you are more likely to discard things that are actually beneficial. So neither one of these is a really good idea. The next thing you can try to do is enhance the effect sizes. Now, you can't make a drug more effective than it is, or hand washing more effective than it is. So what can you do that would actually allow you to legitimately increase effect size? The first thing we talked about is actually try to come up with more homogeneous populations, because that will decrease the variability. You can also try to look for what's called effect modification. Is there some group in whom you think this intervention is more likely to be effective, and then study it in that population? So in other words, like I said, penicillin was actually way more effective in older people who were sicker than it was in younger, healthier people. So you could get away with a study that's way smaller if you studied the effect in older, sicker people. And by the way, answer a more clinically relevant question, because the young, healthy people are going to get better on their own most of the time anyway. So what that does, though, is it affects the generalizability of your results. So if you study a more homogeneous population, you can only draw conclusions about the population that you studied. But this requires what we talked about at the very beginning, understanding the natural history of the disease and evidence from prior trials. So one of the things that really hurts you is enrolling participants in a trial in whom the effect is expected to be 0. So you do an ammonia trial that has lousy diagnostics, and you enroll a bunch of people with the common cold. You're not going to show anything in those people because they don't have the disease you actually were interested in. So luckily, oncology and cancer drugs have been going this way for some while in terms of developing agents that are more specific to specific types of patients. So for instance, the monoclonal antibody trastuzumab, which is called Herceptin, has been used for breast cancer. It is only effective in people who are HER2 positive and have that specific genetic mutation on their breast cancer, which is only about 20 to 30% of patients with breast cancer. In the other 70 to 80%, it's potentially harmful. It certainly doesn't help them. So you want to specifically use this in people that are HER2 positive to begin with. So that is studying a more homogeneous population, and you can actually use a smaller sample size, and more importantly, avoid harming people that can't benefit to begin with. Another issue is optimizing exposure. So some preclinical information or data from healthy volunteers may actually help you pick the right dose that you want to study in a future trial going forward. Or if you're doing a study with a drug that may have high variability in the population, you may want to check blood concentrations in the blood. Now that needs to be done by evaluation through a unblinded third party to maintain blinding of the study. And again, you'll hear some more about these various types of interventions and studies when we get more into the course. I'm just, again, giving you a flavor of some of the things that you're going to hear about later. The next kind of thing you might want to do is use continuous instead of dichotomous outcomes. Now, what do we mean by that? Continuous outcome is one where you collect data continuously over time as opposed to just measure it at one point in time. So suppose like what I'm doing in the influenza studies, you want to look at the time it takes people to get over their symptoms for influenza. That's a continuous measure. On the other hand, if I look at how many people are over their symptoms on day 10, when do I measure that? One time, on day 10. So there's not as much information being captured, and therefore I don't have as much ability to detect differences. Now what that does do is it requires more frequent data capture. So what we've been doing now is using patient diaries electronically that people can get to over the internet and fill out at home. So they don't have to be in the clinic to be able to do this. So here's a good example of this. This was a study that was published a decade ago comparing ciprofloxacin to azithromycin in cholera. So notice that more people got better with azithromycin faster than on ciprofloxacin at 120 hours. If I went beyond this, everybody's better in both drugs. So would I be able to detect this difference between the drugs if I looked at how many people were better on day 10? No, I'm going to completely miss it. So This time to event analysis, which is the continuous measure, was able to detect differences that you would not have found if you used a dichotomous yes-no at a specific point in time out here. So the next thing is selection of outcomes. So getting outcomes that are more common actually allows you to detect differences. Now, the problem with that is that the more common events may not be the things that you're most interested in. So there's a trade-off here between those things. So sometimes people do what's called composite outcomes, where they look at multiple things that might happen to somebody. So but the problem is that results in issues with interpretation if what you're combining together is not equally important to patients. So for instance, the cardiologists get this right. They use a composite outcomes in cardiology trials of death, stroke, and heart attack. Those are all bad things to happen to you. On the other hand, in oncology, they have an outcome measure called progression-free survival. Progression-free survival means you're alive or dead, and your tumor shrinks or it doesn't. They are not the same thing. And if I gave you the choice of do you want your tumor to shrink or do you want to be alive, you'd choose the latter. So the problem is these two things are very disparately different for people. One is really kind of a laboratory radiologic finding, and the other is a direct benefit for patients that is not like death, stroke, heart attack in cardiology. So, and it also doesn't necessarily imply benefit on all parts of the outcome. You could shrink the tumor, but nobody lives any longer. So, because most of what the outcomes are going to be in the tumor shrinkage piece. Here's what happens sometimes when you combine things together. So this was a hypothetical, this is an article on composite outcome measures by Lupson. And what they did was they came up with a hypothetical trial where the outcome was patients either died or were hospitalized. So if you look at this, it looks like only 5 people in the test group died and were hospitalized, and 15 people in the control group. That's great. So 3 times as many people had bad outcomes in the control group. So this new stuff's great, right? Well, wait a minute. We didn't count the people who died because they never got to the hospital and dropped dead at home. That's the exact opposite. So when we add it all up, there's no difference between the test and the control group. So how you formulate these composite outcomes is really important. You can't leave out things that may be relevant to the patient. So getting hospitalized and dying, yep, that's important, but if you died at home because this stuff was so bad it killed you fast, that's not a good thing either. So you need to think about those ahead of time. So what are some ways to decrease variability? So decrease variability. So we talked about effect size, right? That was moving those curves further apart. On the other hand, decreasing variability is taking the width of that curve and making it narrower. That's the other way we could decrease the sample size of a study. So the first thing is to come up with better measurements. So when you do a measurement, there is the true value and there's always some associated error with that measurement. Well, one way to make that better is decrease the error. And there's 2 types of error that we already talked about. Random error, which occurs by chance alone, and systematic bias. So by coming up with better measurements, you can decrease some of that error, which will decrease the variability in your data. So remember I said earlier about what the problem is when you allow clinician judgment? So this is a really cool study that Archie Cochrane, who the Cochrane collaboration is named after, did in the 1950s. He took a bunch of coal miners in South Africa, and he randomized the coal miners to 4 groups of doctors. And he told the doctors to go ask these people about their respiratory symptoms: cough, sputum production, chest tightness, chest pain, and dyspnea, which means shortness of breath. So these are all the same coal miners. So what we ought to see is the number of symptoms should be flat across A, B, C, D, right? Same people should be the same amount of symptoms. Look at this variability, right? So these docs got all sorts of different answers to the same patients about whether they had cough, sputum, dyspnea. So, and it also may be how much the particular doctor thinks that thing is important. So Dr. A must love cough, but doesn't think too much about sputum, right? Whereas Dr. C here thinks that, I'm sorry, I got it the opposite way around, right? Dr. C is more concentrating on cough, but less so on sputum, and Dr. B thinks shortness of breath is the more important thing than Dr. D does. This is the same exact measurement being made on the same patients by different people. Because it's vague, because it's left up to judgment, this is all variability. This is what you don't want in your study because just that kind of variability is going to result in a bigger sample size for nothing, right? You're not actually more accurately measuring what's happening to the patients. You are more inaccurately measuring what's happening to the patients, and it results in you needing to do a bigger study. So coming up with a better outcome measure. So that's why we're trying to develop patient-reported outcome measures that directly ask the patients about their cough, chest pain, tightness, etc., because that will actually decrease the variability by asking patients those questions in a standardized way. This is another great one. So you're thinking, that's all just subjective symptoms. If we use more objective findings, we won't have this problem, right? So Chuck Mortel did this study in the late 1970s where he took marbles and put them between two sheets of styrofoam, or this kind of stuff that covers the microphone, squishy stuff. And then he had the doctors measure the size of the marbles. What the doctors didn't know is two of the marbles were identical in size. So he was able to measure both inter- and intra-rater variability. And what he showed was that the marbles that were the same size, they had a 25% reduction in their size based on the doctor's measurements. So he was doing this. He was an oncologist. And what he wanted to show was that doctors' judgments about tumor size were pretty variable. So what it showed was that the same marble of the same size got 25% smaller when you left it up to the doctor to judge. That's amazing. That defies the laws of physics, right? So I need these guys to do my taxes for me somehow, that I can, reduce my tax bill by having these dudes look at it and get 25% smaller. So the interesting thing is that reduction is way smaller, way bigger than the average tumor shrinkage in a trial. So that much noise is really is measurement error alone, it's going to sink your trial to be able to actually do that. So this is and the reason I put this in here is just to show you the percentage of approvals that have used patient-reported outcomes. Now this data is old, it's a decade old now, but what it showed was that some places like pain drugs have been using patient-reported outcomes for a long time, gastrointestinal drugs have been using it for a long time. Here's my part in infectious diseases, 0. So I guess when you have the flu, you don't have any symptoms, right? Of course, you feel fine when you have the flu. So it's kind of crazy that in antivirals and antibacterials, we haven't been using any patient-reported outcomes. Now there's a reason for this, right? When penicillin first came along, it was when people died from infections. But now that we have agents that are actually effective in prolonging life, we need to ask the next set of questions, which is maybe drug X is better than drug Y on decreasing your symptoms, and even though it's not any different in preventing death. So we need to start asking these kinds of questions. So one of the outcome measures that's used often in an attempt to shrink clinical trial sizes is what's called surrogate endpoints. And so these are laboratory tests or physical signs which are used as a direct replacement for how the patient actually feels, functions, or survives. So there are some very good examples of this, like viral load in HIV studies and cholesterol as a substitute for measuring strokes or heart attacks in prevention studies. And those have worked very well. What you never hear about are the surrogate endpoints that completely flop because they don't represent what actually happens to the patient. 2 weeks ago, there was a study in the New England Journal of Medicine that looked at people with Chagas disease, a parasitic infection that you get in South America when you're bitten by this particular kind of insect. What it actually does is it infects your heart, it can give you arrhythmias, and kill you from the heart problems. They took people and gave them a drug called benznidazole, and they looked at whether it decreased arrhythmias and death. Didn't do anything between the benznidazole group and placebo. But the surrogate outcome they used was a PCR for whether you had the parasite in your blood or not. Huge difference on whether you had the parasite in your blood or not. Did it do you any good? Nope, you're still dead. Didn't help you. So, so what's interesting is in my field, you hear people say, that's okay. That's all the drug was supposed to do was kill the bug. So one of my friends who's a statistician said here, yeah, I guess if we threw the patient in a volcano, that would accomplish the same thing. The bug would be dead and the patient would be dead at the same time. So that's the problem with these surrogate outcomes is that we think that the intervention works only through that mechanism when in fact there may be unmeasured benefits or unmeasured harms or other pathways of disease that are not measured by the surrogate. So killing off the bug in Chagas disease didn't do anything in terms of decreasing the heart problems. And maybe that's because at that point the damage is already done and it's not related to the bug anymore. It's related to the damage that's happened in the heart, and you need some other treatment for that is unrelated to killing a bug. So lastly is the issue of assuring follow-up of the enrolled participants in the study. This is a key issue where you spend all this time getting people into the study, but don't follow them up. And when you have a lot of missing data in a study, it can really sink your study because then you don't know what happened to those people at the end of the study. And finally, there are some particular types of study designs like crossover studies, N=1 studies, and what's called sequential trial designs, that what you're doing here essentially is using the patient as their own control. So in other words, they would get intervention A, then have a washout period, and they would get intervention B. And you compare what happened to that same patient in period A to period B. Now, there are only certain places where these trial designs can actually be used. And usually, these are most useful in chronic illnesses with a stable course of disease. So if you tried to do this in pneumonia, this isn't going to work, right? So pneumonia, you get sick, you're ill, and you either get better or you don't in the space of a couple of weeks to a month. So you can't cross over to some other drug. You're going to be better, or you're not in that short period of time. Some diseases are also worse in certain times of the year. So there's these things called period effects, which can affect these kinds of crossover trials as well. And it's most useful in diseases where the treatment effect is rapid in onset, or there's a rapid cessation of the effect of the intervention when it's stopped. So you have arthritis, you get put on a drug and you get better in a couple of days, they stop it and you get sick again in a couple of days. So those are the kinds of things where this is actually useful. I'm going to skip over this since we're running out of time. The last thing you're going to hear about sometimes in this course is this issue called adaptive trial designs. And really, adaptive trial designs, I always joke, they always remind me of saying, well, I like food. What kind of food? In other words, there's many ways to adapt a trial. So one of the ways it's been used in the past is you study multiple doses of a drug, and at some point during the trial, you drop out one of the doses because it's very clear that that particular dose is not effective. Those kinds of studies have been done for a long time. On the other hand, you're moving along and you're doing a study on a particular outcome measure, and you look at the data and you say, oops, doesn't look like I'm going to have much of an effect on that. I'm going to change horses and switch to some different outcome that's not as relevant to patients. Well, that's a lot different. You've adapted the study in both those situations, but one of them is legitimate and one of them is not. So you'll hear about this in terms of advantages and disadvantages. I am going to make a caveat on this final slide here, and that is almost everything I've talked about today in terms of modifying studies to make them more efficient is in the setting of trying to show that one intervention is better than another one. That's a superiority hypothesis. There is this crazy thing I mentioned earlier called non-inferiority, which is a misnomer. Now, to you and me, non-inferior means not worse, right? At least that's what I was taught in English class. But this trial design is actually designed to rule out that the new intervention is worse by some clinically acceptable amount. Now, there are places where this makes sense, and the reason for these kinds of trials is there are places where patients may accept somewhat less effectiveness for some other benefit like decreased side effects. So, for instance, uncomplicated urinary tract infections in young, healthy women. Suppose we come along with a new drug that profoundly causes less nausea than an old antibiotic. So a woman might say, yeah, I'll take the drug that's a little less effective in curing my UTI symptoms because I don't want to be throwing up all day. On the other hand, when the outcome measure is death, like somebody in a ventilator with pneumonia in the ICU, how much death is clinically acceptable decrease in effectiveness? The answer to that's 0, right? Nobody wants to die. And in fact, you'd accept a drug with more side effects if it kept you alive, right? So there are places where this kind of hypothesis makes sense, and there are places where it does not. So you'll hear some more about what are some of the issues in designing these kinds of studies. And in fact, some people have held that in certain situations, these trials are unethical because they disregard patient interests. One, because they shouldn't be used in life-threatening illness, and two, because that other benefit of, say, decreased side effects or improved convenience is never spelled out for the patients. So the study's designed to show new drug is a little less effective, but it's never evaluated, okay, so what's the benefit on the other side of that equation, like decreased side effects? If that's not evaluated, then all you've done is put patients at increased harm without being able to tell them they're getting something else on the other side to balance out that equation. So in conclusion, developing an efficient trial starts with planning and a good research question, and then some more planning, and then some more planning. So I just want to get across to you that that's the real key to this, is really thinking about these things ahead of time. The question comes first, and the sample size comes second, not the other way around. And there are various methods to increase effect sizes and decrease variability, which when applied in the correct setting can provide valid and reliable answers to your research question. And for some diseases, developing the tools is a good way to start. For instance, developing better outcome measures and having better data on the natural history before you get to the point of where you want to do clinical trials. So let me stop at that point. Any questions that I can answer? I'll stick around for a few minutes down here if you want to run down and ask me questions. Anything else? Are there online questions, or these people will just email the questions afterwards, right? Okay. All right. Thanks very much. Keeping you from your dinner. Thanks very much.